I'd never seen anybody restenote stents like I had. I think it was all Lp(a) mediated.
Welcome to MedEvidence, where we help you navigate the truth behind medical research with unbiased, evidence-proven facts, powered by Encore Research Group and hosted by cardiologist and top medical researcher, Dr. Michael Koren.
Hi, I'm Dr. Michael Koren, and I'm delighted to lead another episode of MedEvidence. And today I had the great pleasure of talking to Dr. Dennis Leahy, who is a colleague and actually not only an interventional cardiologist, but an interventional cardiologist that has dealt with the problem of lipoprotein A. In our previous discussions, we talked about his history, and now we're leading to the part of his history where he had to decide about what treatment modalities to pursue. And fortunately, he made contact with Dr. Sam Tsimikas, who's considered an expert in this field and somebody who's been very active in therapies that are targeted against lipoprotein A. So, Dennis, I'll let you pick up the story from there. So I think you said you met Sam in 2017. Is that correct?
Right. And part of the good fortune of my story, I guess the bad fortune is I have this problem, but the good fortune is I've had access to world-class healthcare, and that's really gotten me through all this. So I met with Sam, and he was starting.
I'm just going to interrupt you for a second, just
Sure.
to make sure we update the audience. So Dennis had coronary artery bypass surgery after a number of stents were placed. And then a few years later, he needed a carotid endarterectomy to repair a blockage in his left carotid artery that caused a little mini stroke. So he certainly had many, many complications of lipoprotein A, despite having no other cardiovascular risk factors, being a very active person and taking statin therapy. So take it from there, Dennis.
So Sam was working with Ionis Pharmaceuticals, where they had developed this ASO, or antisense oligonucleotide treatment for Lp(a), which is a gene-slowing approach to try to suppress Lp(a) production.
Right.
They'd had one successful phase 2 trial, and they were starting another one. And this is right about the time I just happened to consult with Sam, and he offered the entry to the trial to me. And it sounded like a great option because, unlike other trials where it's frequently a 50-50 chance of getting active treatment, this was a dosing trial, so I had a 5 out of 6 chance of actually being on an active drug. Mm-hmm. So I was in that study for 1 year with, as you know, successful and impressive suppression of Lp(a) production. I think I was on a once every 2 week injection, subcutaneous injection, very simple procedure, which has been shown to be quite safe with minimal side effects.
And this is the molecule that we call pelacarsen now. Is that correct?
Right.
Mm-hmm.
Right.
And antisense oligonucleotide that actually prevents the production of the protein that is essential for the assembly of lipoprotein A right outside the nucleus of the hepatocytes. So that's a fascinating technology and really, really exciting. And so exciting that, as I understand it, Novartis bought the product.
Right. Novartis, of course, is hopefully towards the end of a trial, a major trial that will be a really, really a landmark kind of pivotal trial, whether these things are going to result in lower incidence of cardiovascular events by suppressing Lp(a) production.
Yeah, and we're participating in that trial as we speak. It's fully enrolled, as I understand it, and but here in Florida, we're very excited about the possibilities, and it looks like that product could be the first in class to actually treat the real underlying issue of lipoprotein A.
Yeah.
But keep on going with your story. So you did well in the trial. Do you remember how it actually affected your numbers?
Yeah, my numbers are, I had a 70-80% suppression of Lp(a) levels. My baseline levels are usually 120 to 130. And they came down to, 50, 40, very close to the upper limits of normal. And it was, just nothing for me to do. It was really simple. Again, I bring that up because in contrast to apheresis, which is what I've been doing for the past 3 years, it's quite a different approach.
Interesting. So you didn't have any injection reaction things or any of the concerns of using these type of technologies?
No problems at all.
Okay, so then you went to apheresis. So for everybody out there, that's kind of like a dialysis type therapy where you have to have your blood filtered, basically. So once you tell us how you ended up doing apheresis
Yeah.
and
So just
what that's
to
like.
get back to the timeline. So I was in the trial for most of 2017, part of 2018, and then stopped it and just was on statins and aspirin. And then in 2020, surfing, had an episode of chest pain.
Oh boy.
My graphs now are 12 years old, which is
Mm.
you might expect. I mean, you're just waiting for that moment. And had a stress test, which was pretty unremarkable. There was a very, very minor area of hypoperfusion in the right coronary distribution. So I had an angiogram, and again, credit to my friend, my former climbing partner and surfing partner, who is my cardiac surgeon. The graphs looked fantastic,
Yeah.
and there was a focal lesion in my right coronary artery that would lend itself to stenting, 100% of the time.
Hmm.
Now, my history with stents was miserable. I was very, very concerned about, going down that pathway again. And so Sam and I met and talked and thought, well, at least around the time I'm going to have the stent placed, I want to be on apheresis. I want my Lp(a) level as low as possible, because I'm virtually certain that was what was the cause of my restenosis
Mhm.
problem. I'd never seen anybody restenose stents like I had.
Hmm.
And I think it was all Lp(a) mediated. So that's when I went on apheresis, which I've been doing now for 3 years.
Nice. And tell us a little bit more about that. How often you get it? Is it a hassle? What are your numbers?
Yeah. Well, to answer the second question first, it is a hassle. It's a pretty big undertaking. It's as you mentioned earlier, it's a way of basically filtering the lipoproteins out of your blood, the low density ones particularly. And but because this problem is genetically mediated, your body knows how much Lp(a) it wants to produce, and it keeps producing it. So
Yeah.
when you go to your Lp(a) treatment, your Lp(a) level at 9 in the morning is 130, and when you finish somewhere between 3 or 4 hours after the treatment, that's how long the treatment lasts. Then your Lp(a) level's down to 30. 2
Mhm.
weeks later, it's back to 120.
Mhm.
So it's a process that's been, as you know, it's been around for a long time, particularly in Germany, where most of the research was done. And the thing about apheresis, it is very, very good data. It's observational because there's no way to double blind an apheresis study, at
Sure.
least if you have any ethics. Um,
Yeah,
you're,
it could be a little squirrely for an IRB on that
yeah, I
one, but
think so too. You'd have to
yeah.
be a rare institution that would go for that.
Mm.
But it did, observational studies showed that repeated cardiac events were lowered substantially,
Mm.
actually in the range of 70% in people who were getting apheresis regularly. I think in Germany they did it every week, which would dominate your life. So I did it for every 2 weeks for about a year and a half, and even that
Mhm.
was getting kind of to me a bit. It was basically a lost day, and it was a lot. So I've done it every third week more recently.
And so you're doing that. Any further complications health-wise?
No, I've had no issues. Everything's been fine.
Are you tracking anything else other than just the LPA levels? Any inflammatory markers or other
I haven't been
assessment of
doing
your
that.
coronary anatomy? Yeah.
I haven't been doing that, but I think the whole discussion of the inflammatory markers in Lp(a) is a big issue. I think that will probably enter into how and who should be treated for Lp(a).
How about your carotids? Have you had those looked at?
Yeah, my carotids, I get it checked every 6 months. So I've got about a 60 to 70% right carotid lesion that's been completely stable
Mhm.
since 2017. My current regimen, I'm actually changing it. Sam and I talked a couple of weeks ago, and I've decided I've started Repatha,
Mhm.
the PCSK9 inhibitor, and I'm kind of thinking if that achieves what it has in the first two numbers that I've checked since I've been on it, I may opt out of apheresis because it's actually lowered my. I've been lucky. I'm kind of one of the people it suppressed my Lp(a) level by about 35%,
Yeah.
and which I think on average is probably what I'm getting out of apheresis. So it's a
Yeah.
thought.
Yeah. The PCSK9 inhibitors are really the first class that have some consistent efficacy against LPA. And to the point you're making, the studies are showing, somewhere between a 20 and 35% reduction in LPA in folks in your situation. And of course, really, really nice reductions of LDL up to 60%. So that is truly a breakthrough in terms of treating this dyslipidemia. But 30% is not nearly what we're seeing with some of the newer drugs that we'll talk about momentarily.
Right.
But had just a couple other quick questions to the point on apheresis. Was there any concern about this fluctuation of the LPA level? Some people have talked about that. Is it more important to be consistently low, or just preventing your body from being exposed to high levels intermittently is as good? Any thoughts on that or discussion on that?
No discussion. I don't know if there's any answers to that question. I mean, it's a good question, but I think the general idea is the lower the better, and you'd like to see it continuously low, which and not have to be re-intervening every couple of weeks to get it down. I can only guess if it's just a linear increase between visits or not, but as I said, I think probably in my case, I'd usually start at 120, 130 and finish at 30. Mm-hmm. And so, probably the mean, just if I was thinking of it linear, the mean Lp(a) level would be about 70. I think the average around 80.
And what was your LDL running at that point?
My LDL has always been, because I've been pretty high dose statins. My LDL baseline is about 55, and then it would go down to about 11 at the end of an apheresis treatment.
Yeah, and apheresis can be used for familial hypercholesterolemia also. So that's just LDL problems without the LPA problem. But a lot of people actually have both LDL and LPA problems, and apheresis may be an attractive option for those folks.
Yeah.
So I'm just gonna throw one thing out there, and then we'll take a quick break. But when we talk about these different therapies, they have different mechanisms. So we just talked about apheresis, which is basically a filtering mechanism. That's been around for a while. I was first exposed to that actually as a cardiology fellow. During my cardiology fellowship in the late 80s, early 90s, we had a program where apheresis was done for severe lipid problems. And as I mentioned, there wasn't great buy-in amongst the cardiologists at that time. And it was actually done at the Rogosin Institute of Cornell by the nephrologists. So we had cardiologists having to refer to nephrologists to get treatment of this problem back in that time period. But probably that was the only thing that was effective. Other modalities have not panned out particularly well. We thought that niacin may have some nice effects on LPA, but unfortunately all the clinical trials with niacin really just didn't pan out particularly well for patients in terms of reducing adverse outcomes. So that kind of fell out of favor. But then the PCSK9 drugs and the two that are the two antibodies that are on the market are Praluent and Repatha, as you mentioned. And what they do is they lower LDL tremendously by upregulating the effects of the LDL receptor, so that the LDL receptor can remove these bad lipoproteins from the circulation. The thought prior to the Repatha data, quite frankly, was that the LDL receptor did not work at all to remove lipoprotein a. And to sort of remind the audience, lipoprotein a is basically an LDL molecule that has some extra protein components that make it a molecule that the LDL receptor cannot remove from the circulation. Therefore, it just hangs around and causes havoc and potentially inflammation. But interestingly, with Repatha and Praluent, the antibodies, we're seeing that when you got the LDL down far enough, then the affinity for the LDL receptor may get to a point where the LDL receptor can actually remove some LPA. So that was interesting, and maybe the mechanism that's operating in your case. But again, unfortunately, that's still only about a 30% reduction, and most people in your situation need way more than that. Just in fairness, inclisiran, which is another drug, small interfering RNA, that also uses a PCSK9 mechanism, is also effective against LPA. Maybe not quite as much as the antibodies, but again, they haven't really been compared head-to-head, so I won't speculate on that. But bottom line is that we have something out there that does have some effect on LPA, but not nearly as much as what we think the next generation will hold.
Thanks for joining the MedEvidence podcast. To learn more, head over to medevidence.com or subscribe to our podcast on your favorite podcast platform.